But however, this brings me, Anthony, to your very important story about nivolumab. And if anything, you yourself personally contributed to ultimately the FDA approval of nivolumab in the second-line setting. And now, you know, Ruth and I are having great time. You were talking about 24 months and great response to a TKI, and then you come from the left field with a drug called nivolumab. So tell us a little bit more about that.
So nivolumab is the anti-PD-1 antibody, one of the checkpoint inhibitors that have shown efficacy, one of the many that have shown activity in many tumor types. You know, if we go back 4 or 5 years ago, we never thought that we would test these in liver cancer, because we always thought the liver is such a tolerant organ, there is no immune suppression. But we've learned over time that liver cancer, like other cancers, have many mechanisms by which to shut down the immune system and prevent it from recognizing the cancer and acting against it. So the goal of nivolumab is to remove one of those breaks, one of those checkpoints, the PD-1, PD-L1 interaction, and reawaken the T cell to recognize the cancer and act against it. So the evaluation of nivolumab so far has been as part of a phase 1/2 study known as Checkmate 040, which ultimately led to the accelerated approval in September of 2017. Briefly, the dose escalation part of the study, which was about 48 patients, you know, it taught us that this was a safe approach, that the side effect profile of nivolumab in liver cancer was no different than other tumor types. And the dose that was adopted as a recommended phase 2 dose was the same as other tumor types, 3 milligrams per kilograms, or the fixed dose of 240 milligrams. Subsequently, there was an expansion of 4 different cohorts that totaled 214 patients, where we learned a little bit more about the activity, and that was published already with an overall response rate of 20%. You mentioned the survival excitement with the sequence of sorafenib followed by regorafenib, which is, again, certainly exciting. Some of the early survival data with nivolumab comes from an analysis we did by looking at the sorafenib naive patients, which were 80 of them in this phase 1/2 study, and their median survival was about 28 months. And then the patients who were sorafenib experienced, most of them were had progressed on sorafenib, their median survival was about 15 months. So these are very promising, exciting numbers compared to what we're used to. And again, hopefully offers another option to patients.
Great. But Catherine, probably we're now like, whoa, these guys, oncologists, were giving TKIs, some side effects, we can handle it, we'll talk about it. But now we're talking about changing immune modulation and immune system, and you kind of coming from the world of liver transplant, like what do you think is there to be of concern? Because especially from the toxicity standpoint, because no question this is a great drug, as we just heard from Anthony, but at the same time it's not necessarily a walk in the park for everybody. But tell us what will be your concerns from the liver standpoint in regard to the application of a checkpoint inhibitor.
So I was not surprised to see the immune checkpoint inhibitors have activity in HCC, because we see people who have liver transplant for cancer and then recur post-transplant. When they're on the immune suppression, the cancer progresses a lot faster than patients who are not on immune suppression. So it does make sense that this interaction with the immune system would have an effect. The concern is for the patients who've not been transplanted or don't have any autoimmune problems. There have been reports of autoimmune hepatitis and specific liver damage with these checkpoint inhibitors. Now, the percentage is low, less than 5%. However, it can be quite severe, and patients can actually go into liver failure because of the autoimmune issues with the checkpoint inhibitors. In the transplant population, we do not want to have anything to do with immune checkpoint inhibitors. After transplant, there's been several studies of patients getting the checkpoint inhibitors, say they've had a kidney transplant, now they have metastatic melanoma, and rejecting that organ. Now, if you have a kidney transplant and you reject it, you go back on dialysis. But if you have a liver transplant and you reject it, you're in trouble. So that's a big concern. We also don't know how long the effect on the immune system lasts. So we don't know what will happen if patients get an immune checkpoint inhibitor, have a response, and now they're potentially somebody that could go to transplant. What would happen with those patients? So at this point, we're avoiding immune checkpoint inhibitors in anyone that potentially could go on to a liver transplant down the line.
And along that line, this is very important, and along that line, would you consider anybody might not be eligible for checkpoint checkpoint inhibitor, other than what you suggest about the potential transplanted patients?
So other than, in terms of patients who would not be eligible for a checkpoint inhibitor, other than the potential transplant patients, I would worry about patients that have autoimmune diseases like autoimmune hepatitis or PBC or PSC or rheumatoid arthritis or really any autoimmune diseases, because we have seen patients who get the immune checkpoint inhibitors and can have very bad flares of their autoimmune diseases they already have underlying.